Hi everyone, today I'd like to talk about the many types of regenerative procedures that I do for tendon and ligament injuries, and today I'll focus on the distal biceps tendon. In this patient, they felt a sudden pain in the elbow and biceps muscle while under a heavy isometric tensile stress. They thought perhaps it could be some sort of muscle tear, and so we did some quick imaging and pretty quickly found this defect in the distal biceps tendon. In the posterior aspect, you can see that there's a loss of the fibrillar structure of the tendon, probably about 30 to 40% of the thickness of the entire distal tendon. So that posterior portion is the lateral long head, and as we'll see in a minute, it has this interesting anatomy where it rotates and converges with the short head tendon and inserts onto the radial tuberosity. So the short head distal tendon was intact. From another side view, you can see here there's again a tendon defect in the posterior aspect of the distal tendon with some surrounding hyperechogenic material. And this is in the middle of the tendon where there's the least amount of vascularization and blood supply, because at one end you have the vascularization from the muscle and at the other end the vascularization from the bone. But in the central region, this zone 2, there's the least amount of vascular supply. In a cross-sectional view, you can see in the distal biceps tendon, again, in that more inferior aspect of the tendon, again, a defect of missing fibrillar material. And further up, again, that defect begins to diminish as the tendon spreads out into the connection to the musculature. Now, there was also a lot of tendinosis at the upper tendon origins, which I won't address here, but the biceps tendon itself does not have a sheath. There was no tenosynovitis, and everything else looked fairly normal. There was not any joint effusion, maybe a little bit of bursitis associated with that more lateral side at the posterior aspect of the tendon tear, and there was no brachialis tendon pathology. So with a bit of looking around from many different angles around the elbow, you can see through the back of the forearm muscles, while rotating the hand out away from the body in this sort of swan shape, you can expose the radial tuberosity fairly well. And here again, you can see the footprint of the insertion of the distal biceps tendon onto the radial tuberosity really well. Now, when you scan over the ventral aspect of the elbow, you can get a really nice view of all these structures, including the elbow joint itself, as well as the vasculature and the distal biceps tendon and the nerves. So this is sometimes called the toad view because it kind of looks like a toad, or also the Java view because it looks like Jabba the Hutt. And along with that, here in this particular patient, we can see again the defect at the long head of the distal biceps tendon and retraction of all those fibers into the myofascia around the lateral head of the bicep, or the long head of the biceps. Now, surgery is typically recommended for tears over 50% thickness and ideally within 14 days of injury. And I won't go into all the nuances of that or all the surgical techniques that are available, but ultimately none of them can quite restore full strength and function back to the original. The biceps tendon itself is torn, so if there's more than an 8 centimeter retraction, then that indicates that the lacertus is also ruptured. And you can get these Popeye deformities, the bulges of muscle, even with only partial tears. These diagrams from these research publications are showing how the distal tendon makes a 90-degree rotation, with the long head staying lateral to posterior and the short head going from medial to more distal on the radial tuberosity insertion, and also showing the vascularization in zones 1, 2, and 3 of the tendon like I discussed. So with tendon injuries, I use this substance called PRF, or platelet-rich fibrin, which can act as a scaffolding. It's sort of like a biologic glue that can adhere around the tendon and activate platelets while also providing some structural support and growth factors along the tendon injury. And I can do this under minimally invasive image guidance. And the PRF also can act as an anchor or a tether to hold stem cells at the injury site, which can aid with stem cell survival and integration. It inhibits this process where mesenchymal stem cells will undergo anoikis or cell death when they're not adhered or attached to something. So your own mesenchymal stem cells from bone marrow are primed for this lineage of orthopedic tissues like tendon and ligament, cartilage, fibrocartilage like the labrum and meniscus, and other connective tissues. When planning these procedures, I always take an approach that allows ideal targeting of the injury for optimal repair and also avoid any damage to tissue structures. And so there are many possible approaches to each type of injury, and I really adapt based on the specific things that we're seeing on imaging. So knowing the surgical anatomy is really important here as well. They suppress collagen synthesis, and they're known to weaken tendons and ligaments and other connective tissues. Plus, they slow tissue healing, which contributes to this underlying connective tissue weakness. So that is not a good idea in the long run. I much prefer the regenerative agents like stem cells, PRF, A2M, and others. They create, like I said, this scaffolding of growth factors and regenerative agents that help stimulate the tissue to repair itself, and also creates binding sites for mesenchymal stem cells and platelets to anchor and again to help strengthen these tissue defects. There's a lot more that you can see on the website alpineathleticmedicine.com, both under PRF and stem cells, with lots of citations and references on the studies that are being done in this area. Now, with this particular injury in this patient, I did an injection of PRF at the site of tendon rupture with stem cells, and you can see here the needle took this precarious approach directly under the tendon and artery, and I just laid it along the surface of the defect on the distal tendon. And because of this particular approach, I was able to get right along the defect underneath the tendon and really target that long head of the biceps degenerative phase where they're trying to make more collagen and bind onto the collagen that's there, but it ends up being just this inflammatory rut, or this degenerative rut even, of mushy collagen or gelatin that's not well attached, not well organized, almost like scar tissue, this mucoid sort of mushy, denatured, gelatinous type of collagen that just festers and never quite allows the tendon to bind and heal and form new cable-like structures with these collagen fibrils. And so what I'm doing here is a lot like just spot welding by attaching with PRF these tendon fibers back to the muscle and the fascia. And when I do this, I obviously don't want to put the needle through the tendon because that would do more damage to the tendon. So I take a careful approach to really go along where the injury is and just sort of spot weld these things with growth factors and with binding scaffolding to help it heal. So I'm showing a few quick examples here as an overview of the treatment for this patient, where I targeted various aspects of this tendon rupture and defect. And again, the goal is to surround the injured portion with PRF and stem cells to help adhere them in the area where they're needed most, and not just allow them to diffuse and die off and disintegrate. So this really keeps the growth factors where you want them and gives that structural support and scaffolding to the tendon sheath and the tendon fibrils. After these injections, there was just minor soreness, and he was able to quickly begin a physical therapy program, which over the next 6 weeks dramatically improved his strength and mobility, and he continues to do physical therapy and is doing really well with his strengthening exercises. So thanks for watching, everyone. Feel free to ask any questions, and please like and subscribe to see future videos that I'll be posting about a wide variety of regenerative repairs that I do. I'm really trying to lead the way in minimally invasive, image-guided regenerative interventions for many orthopedic, spine, joint, and nerve injuries to give my patients the best outcomes and restore their quality of life without going down the road of destructive surgeries, and instead regenerating, repairing, and regaining good activity and function. So thank you.